Up next is another anesthesia talk from another great partner and advocate and ally from within anesthesia, Clint Allred. Clint is a CRNA who is going to talk to us about the protocol we've used to decommission centrally supplied nitrous.
Okay. Wonderful. It's great to get to be here with you today. Sounds like it's been a great day so far. I was telling my wife earlier this week, I said, I don't even know how I ended up here. I was so far, everybody who's here and who's listening online is so far ahead of where I was at. I was on the other end of the spectrum. I liked using desflurane, and I liked using nitrous, and I liked using them together. Even better. And so when Dr. Deutsch, which I have a ton of respect for him and what he's done, I'm the chief CRNA in our group right now, so he came to me initially and said, hey, this is what we want to do. And I thought, there's no way. There's no way. And I even sent him articles and studies and case reports of why we should be allowed to use these things still. And I can tell you over several years, I'm now here presenting on something that I really think can make an impact. And I have truly done a 180. So for the question earlier about how do we do this, it can be done because I was on the other end of things. So Dr. Deutsch did a great job talking about the effects of some of these gases, and I'm going to specifically talk today about nitrous. And not even so much the properties of nitrous, but what we've done within our healthcare system and some of the results and some of the things that we've seen. So we've already talked about the environmental footprint that nitrous has. It is a huge contributor to the depletion of the ozone. It's the gas that impacts ozone depletion the most, in fact. And we use it all the time, or we used it all the time. I didn't know any of that. I didn't think about it. There's actually an ASA statement now that talks about recommending transitioning away from the piped nitrous to E-cylinders, which is a pretty big deal to have your national, industry expert making those kinds of statements. This nitrous we found, obviously it's being used. A lot of people know that it's used at your dentist's office, right? But we use it in the operating room. We used it in the emergency room. Use it a lot in labor and delivery for patients. So nitrous is something where desflurane is an anesthetic gas that's pretty much, just anesthesia touches that. It's used in the operating rooms. Nitrous is used throughout the hospital. And we thought, well, this is going to be pretty easy, right? We're saying we're going to be fiscally responsible and we're going to be, environmentally sound. This should be a pretty easy thing, and it is not. It was not an easy thing. But finding that champion and someone who's willing to do, get out there and work on things is exactly what we needed. I've got a little video here. Hopefully this will work. Maybe. This video is us in one of our meetings, okay? This is what it looked like. Many of you have probably seen this. We went through this a lot. Out of the rut and back in the rut, okay? That's what we went through a lot. That's what it looked like. Again, like I said, I thought this is going to be easy. We're saving money. We're saving the environment. Everybody's going to get on board. And we'd get pulled out of the rut, and we'd bounce right back into it. Anyway, one day I remember talking to Dr. Deutsch, just being extremely frustrated after one of our meetings, thinking, why are there so many barriers to this? And he had great advice. He said, we are just going to take this one step at a time. I wanted to do this project and be done with it in 2 months and 60 days, and we were all good. And it's been several years. And he has, that's exactly what it's been. It's been one barrier at a time. It's been one meeting at a time. It's been one department meeting at a time. And it's working out. So I'm going to talk to you about the trial that we did and how we've gotten to where we no longer have any piped nitrous being utilized within our healthcare system. We've transitioned, as Dr. Deutsch said, we transitioned to e-cylinders primarily from the piped. So we decided first we needed to delineate who is using nitrous. We had some really fun conversations with this. We had departments tell us, no, we don't have any nitrous up here, we don't use it. Sure enough, it's piped there, right? We have one hospital, even within our system out in Nampa, that came online in 2017, and they use nitrous in their labor and delivery floor, and it's piped to the walls. We didn't even know that. I didn't even realize that. In the new hospital, they piped it right into the walls for ease, for nursing, right? Makes total sense. And we didn't even realize that going into it. So we had to figure out, first of all, where nitrous was piped to, and who was actually using it, and who was aware that they had it. And then we went through each of those 50 anesthetizing locations, and we made sure they had full nitrous tanks. We found that there was a lot. We were leaking more nitrous than what we were actually using from the piped cylinders. They're called G cylinders, they're the big cylinders. We were losing more nitrous just from leakage than what we were actually using, right? Which is just, it's amazing, right? And so we made sure that we could shut off all of those G cylinders, and that each of our anesthesia machines had the E cylinder on the back of it. We had to make sure we had proper storage for where we were going to keep these E cylinders that we were transitioning to, and making sure that there was ready access. As you can imagine, as anesthesia providers, we wanted access to as many tanks as we could get our hands on, right? We wanted to make sure we weren't going to go into an anesthetic without a tank. So we had dozens of tanks being stored. And then came the education piece. The education piece to the anesthesia providers, this took a lot and is still ongoing. We had to educate why we were doing this trial, how to do a proper machine checkout. Now, that sounds so simple because we learn it and we do it in school all the time. But then you show up and it's piped. And so we had to re-educate on how to do a machine checkout. We talked about cooking, okay? We use the analogy of cooking with nitrous. Believe it or not, nitrous is not an essential element of an anesthetic. Sometimes we feel like it is, and there are certain patient populations we would like to have nitrous for, but actually talking about there's not going to be any harm done to a patient if you don't have nitrous. And that was new for some people. That was something that people had to wrap their heads around, right? And then we had to talk about the storage tank properties of nitrous. Nitrous is stored as a liquid. So your gauge will read that it's full until it's not. And then it's empty. It's not like other gases where, it'll kind of slowly, your gauge will show that you're running out of the air in the E cylinder. Nitrous is different. It's full until it's empty. So we went through all these things and all this education. And then came the big day. It was time to unplug the machines, or unplug the nitrous from the machines. And we ran this trial for 12 months, and our big data reveal came that out of all those anesthetizing locations, we went through 4 tanks a month. That was it. 4 of those little E-cylinder tanks. We had dozens of tanks stored, just in case, right? We didn't want to run out. We wanted everybody. 4 tanks a month. That's it. And most of those were in our pediatric suites. So from there, we were able to go and say 4 tanks a month, we can transition to not having piped nitrous, which was a big project. We hung up these signs in each of the rooms. Remember to turn your tank on, turn your tank off. This little QR code leads you right to the ASA's website on why we're doing this, on the good that can come from this. And then we came back to the table and we said, okay, here are some gaps in learning opportunities. We found out that G cylinders, we still had to have them hooked up. You can't just depressurize a piped system. Or I don't know what happens. But you can't do it, apparently. I don't know. Something bad happens. So we still have these G cylinders hooked up. They're just kind of capped off at the walls. E cylinders also will leak if they're left open. Don't worry. It's not like nitrous is just leaking out into the operating room and everybody's, enjoying surgery more. It's mostly there's leakage that's happening to the internal components of the anesthesia machine. But they do still leak. If you don't turn them off at the end of the day, they still leak. And we continue to educate our staff. So our next steps, just so that you're aware of this, we're getting bids on decommissioning those G cylinders and those pipes. That takes money as well to pull them out of the actual infrastructure of the building. But just so that you're aware, since we've started doing this, we've kind of had two projects going on. We had a surgery center. It's our Center for Orthopedic and Sports Medicine Surgery Center come online. And we were able to catch it just in time before they put in the piping for nitrous. And so that facility, there's no pipe nitrous in the building. Then we have a downtown campus improvement project that's happening right here in Boise that some of you are probably involved in or well aware of. And we went to the architects and right from the ground level, they told us that just pulling that piping out from their plans was a $500,000 savings. That's before you get into any, purchasing of the nitrous and anything. And then we felt like this is our chance to go ahead and parlay those savings into something that really benefits us. And we've been able to work with the hospital system to where there was kind of some restrictions and limitations on some of the other medications that we used. And we were able to go and say, hey, if we're able to do this and save this money, can we have a little lenience here? And they were great. So you can parlay some of this cost savings into maybe something else that you're looking for or that your group needs or your hospital system needs. And now the big part is we're just trying to develop the playbook for distribution so that this can be something that, definitely will have hiccups and barriers, but maybe somebody doesn't have to go through the same growing pains that we went through. So that's been our nitrous decommissioning project that we've had ongoing, what I was hoping would just be a 2-month quick project for several years now. But that's it from me. Does anyone have any questions or comments? Our anesthesia provider, good. I'm so glad she's here.
Isn't there an overhaul, declining use of nitrous across the country?
There is, absolutely. And that's what's really, I think, going to help, especially in the future, is a lot of people are coming out of school not heavily reliant on nitrous, like the rest of us were. Our group, we have a lot of experienced providers. Is that fair to say? More experienced providers. And they're really, we trained with it. I mean, you like what you trained with, what you're familiar with, what you can just plug and play and kick back and have a good anesthetic. But a lot are coming out of school, you're right, that aren't as reliant on nitrous. So that's going to help as well. Okay. Thank you, guys.
Again, let me just share some data about the great work that they did. So prior to the pilot, we used 42 G cylinders over a year, 42 of the big cylinders for central supplied nitrous. The year of the pilot, when we were using none of it from the central supply, we still needed 30 G cylinders to keep the system pressurized. So we waste 30 cylinders out of the 42 that we used the year before just to keep the system pressurized. And this is in a system that we thought was super efficient, that we were checking all the time, that building services was 100% sure was not leaking. There's just never been a study that's been done that has shown that you're not leaking nitrous. So great job from Clint. We're still working on it. We do have final approval to decommission the Boise site and should have that done sometime relatively soon. And then we're working on Meridian and Nampa next.